Orientation purpose. The purpose of gathering everybody today was to describe the changes that are going to be in effect this January. We needed to make sure that folks understood what the revisions are and the purpose for them and what your role will be. To describe the reasons for the revisions and to provide a method for ongoing feedback. Now, I did tell you how you can provide your ongoing feedback. At the end of this presentation, we have Beth Strategies' email address up there. So you want to make sure you hang on to this PowerPoint because she's going to be the first person you contact for your ongoing feedback. And believe me, your feedback is extremely valuable to us. So, what's driving these changes? Delmarva collects, as I said, we collect feedback from all sorts of places, from individuals, from family members, from quality council events, from family care staff, family councils. We collect information from providers. We get information from regional staff, feedback from ARCA and so on. Now you know we can't possibly stop the process and make changes constantly. It would drive us nuts and it would drive you nuts. So periodically, we take a look at all of the feedback that we receive and then we go ahead and we update the tools and the processes. And this is exactly what this round is about. We want to be responsive to all of your feedback. We hate for people to think, well, what's the point of giving them feedback? They don't do anything with it anyway. That's not true. And I'll give you a few examples just so you notice how we have used the feedback. And then very important is that there were new rules from the Centers for Medicare and Medicaid Services, CMS. I'm not so sure how many folks are familiar with CMS, but they play a very big role in what we do. So those are the reasons. So before I get into the new CMS rules, I want to just provide you with a couple of examples on how we have used feedback to make changes. Not so long ago, from attending work groups and meeting with providers and so on, we did find providers telling us that our documentation requirements were too heavy. So we got together with APD and ARCA, and we took a look at it and decided that that makes sense. You're not going to see a progress in somebody every single month. Maybe it's more reasonable to ask for quarterly summaries for services rather than monthly summaries. And most of you guys know that went into effect already and has been in effect. Another change that is coming now is that support coordinators told us, hey look, it makes more sense for Delmarva to review us by region rather than by area. And you know what, when we looked at it, it made absolute sense. Provider caseloads can go up depending on how many regions and so on you serve, and how many areas and so on you're located in, but not support coordinators. They have a limit to how many people they can serve. So it made total sense, and we said, okay, let's go ahead and let's adopt that. So every single bit of input that you give us, we take, we use, and we try to make changes. Let's get into the meat of why we're doing this, besides the fact that we want to be responsive and make sure that people know that they are heard. New CMS rules went into effect in January of 2014. Actually, they came out with them in January of 2014, revised them again in March of 2014. They are currently in effect. So we need to go ahead and make sure that we are in line with those CMS rules. But just so folks have a basic understanding, because I'm not really sure, what each person's understanding is of CMS and the role that they play in what we all do. States go ahead and work with the federal government, which is CMS, to administer the waiver. Now, for every dollar that APD spends on services, CMS puts in a 75% match. So 25% comes from the state, 75% of the dollars for services come from CMS. In return, CMS says, well, I want some assurances from you as a state as to how these services are going to be rendered to people. Here's the funding. In return, you send me an evidentiary report and identify when those reports get sent to them, and there are certain measures that you have to send me that say that you're in line with what CMS expectations are. Now, typically, CMS expectations revolved around health, safety, abuse, neglect, and so on. And while, the intent was there for person-centered services, it was not spelled out. But back in January, when they made the change, it was completely evident and completely clear that there was a heavy emphasis on person-centered planning and person-centered implementation. So Teresa, when she does her bit today, will take you through the changes in our tools and how we are responsive to what CMS expects. At a certain point in time, we will have to gather up all of our data regarding the expectations from CMS and provide it to ARPA and APD to develop evidentiary reports that go to CMS, at which time CMS says, well, yeah, you're doing a great job. The state keeps the waiver. Or you're not doing such a great job. You're now under sanction. It used to be that CMS would just say, you no longer have a waiver. Well, thank God they have moved away from that, and now they apply sanctions. So you get an opportunity to fix whatever the issues were. But as a state, we all want to shine. We all do what we do for the same reason. We want to make sure that we are involved somehow in improving people's lives, in making a difference in people's lives. And that's what this is all about. To be specific about some of the assurances, as I said, there's person-centered planning, person-centered thinking, and implementation. The other rules have to do with community integration. And there's no ifs, ands, or buts. CMS is very, very clear. It means community integration, meaning that you are in the community and having the same access as people without disabilities. So that's the direction that is expected. And then the next one has to do with the settings that people access. And that's residential and day settings. Again, they're very specific about what is not considered an integrated setting. And I invite you to take a look on the CMS website because there's tons of information there that I think can help you. At some point, we will go ahead and post some of that information on our website to make it easier for people to access and so on. So you can take an in-depth look at what the assurances are and what the expectations are and know where Delmarva is coming from. And maybe that will better help you guide your services and even your questions to us. So I think the more information you have, a better job you will be able to do. Just to give you an example, when we are looking at people's residential settings, it's a pretty in-depth look because now we're looking at, do people have access to all areas of their homes? Do they have choice and control of their lives and their homes? Do they control their schedules? Do they even have a key to their homes? If not, why not? What kind of programs are in place? If there are any restrictions, is there a method to get rid of that restriction? So I think you want to pay careful attention to the information we share with you today. We want to be upfront, we want to be transparent. This is not a gotcha program. We try our best to work with you. I remain open to your feedback, whether you give it today or you call me. And I'm going to go ahead now and turn it over.
Good morning. Let's start off by talking about what is the same. I know everybody came to find out what the changes are, what the updates are, but let's leave a little bit of your fear to talk about what's the same. The standards and requirements are taken directly from the Medicaid waiver coverage and limitations handbook. That hasn't changed. As always, we try to remain as transparent as possible. Our tools, our processes, our procedures are all located on our website. All of our review processes continue to include feedback from persons receiving services, documentation, provider input, and observation. Now on the screen you'll see all of the services that we will be reviewing over the course of the next year. The discovery processes include two major components. The PCR process, also known as the person-centered review process, which assesses the support delivery system from the perspective of the person who's receiving the services. Also, the provider discovery review process, also known as the PDR process, which evaluates the person's satisfaction, the provider performance, all based on service delivery measures and program standards. Now I'll be turning it over to Teresa to talk about what's changed.
Okay, one question we forgot to ask at the beginning, so before I get into my stuff, I'm just a little curious. First off, how many folks in the room have already been reviewed by Delmarva at least once before? Raise your hands. How many have gone through some kind of review? All right, so quite a few of you. Anybody in the room never yet had the pleasure of a Delmarva review? Any total newbies in the room? Okay, so we've got a few of those. So when we're talking information, we wanted to keep in mind some of you haven't been through this at all. So when we talk about what's the same, you're like, well, that doesn't mean much to me because I haven't done it yet. So I just wanted to get a feel. Also, out of curiosity, any family members, individuals who receive services and such here in attendance? No? No? Okay. So we got mostly providers. Most of you have gone through the review process, and a few of you haven't had the pleasure yet. So, keeping in the same theme that Christy started, we're doing this presentation trying to establish a little bit of time as what's the same and what's different. So I'm first going to start off in this middle part of the presentation. You're going to see a lot of myself and Kristen Allen. I take the lead on the PCR side, person-centered reviews. Kristen takes the lead on the provider discovery review, the PDR side. And a lot of what we do tends to interrelate. So we'll kind of be tag teaming back and forth for the next few slides. So for what's the same on a PCR, and for the folks in the room that are support coordinators, you're most involved with person-centered reviews. So what's the same when we look for a PCR? We're still going to be doing the same type of sampling. The way it works now is we get caseloads out of ABC from all the support coordinators in a room, and we randomly pick 2 names, and that's who's selected for the PCR, and then you get an unannounced record. So we're going to still be doing that. We know historically we try very hard. I know a lot of you think that there's we're secretly hand-picking these folks. I swear to you, and I'm a good Catholic girl, I swear, it is totally random. We've got our analyst people, they throw the names into the computer, and it spits out the names. We've started more recently filtering out if the person's been reviewed in the past year. Now it's even the past 2 years. Let's try to take them out of the mix. The one thing that makes it a little difficult is our CDC. Part of our contract requires that we do a 20% sample of CDC. And there's only so many CDC consultants around the state. So in order for us to get to that 20%, we keep going to those consultants. And if you only serve 1 or 2 people, we keep hitting those same 1 or 2 people. Have folks had that happen before? So, we're going to try to pay closer attention to that as well, and it could mean more and more folks that do CDC and waiver are going to end up with 2 CDC names picked. And that's as long as we have this 20% requirement, it's just the way things are going to work. But for the most part, as far as what's the same, is that sampling methodology, how we do things with a person-centered review, that's going to stay. We'll still be doing national core indicators. I'll talk about that more in a little bit. We still have a medical peer review process, and we're still going to have a record review with the support coordinator. So that's all stuff that's going to stay the same. So what's going to be different on the PCR? Well, we used to use a tool called the IQ, Individual Interview Instrument. It was about 12 standards. It was answered in a yes or no format. Yes this, no that, and if it was a no, we had not met reasons. We've decided to retire that tool. So that tool's going away completely, and it's getting replaced with a totally new interview tool, which I'll be talking about in a little bit. The health summary is still in place, but we kind of rolled it into that new individual interview tool, rather than having it as a separate tool that gets posted. We've kind of blended the 2 together. So that's something that's a little different. The other thing is we have added a formal interview with the waiver support coordinator as part of your PCR. As it stands now, when you go through a person-centered review, we do the interview with the person, and we look at the record, and we kind of informally chat with you a little bit when we're doing that record review. Now we have a tool, a formal tool that will be interviewing you as part of a PCR for that individual. Again, more detail to come later, just hitting the big stuff. And this is probably the biggest one, and this affects the providers in the room. It used to be since 2010 for a PCR, we did an interview with the person, and then we did record reviews for all the providers that served that person. So if you were a provider, you were getting calls sometimes all throughout the year saying, oops, a person you served got pulled into a PCR, I need to look at their record. And sometimes that record review could occur in March, and your PDR could be all the way in October. And you had kind of this disconnect. Now we did find some value doing those surrounded record reviews, but ultimately, we decided the direction we're going to go is to give us more opportunities to talk with people. So we are dropping the service-specific record review piece from a PCR. A PCR with an individual will include a conversation with them, conversation with the support coordinator, and a record review with the support coordinator. Providers will no longer get pulled into PCR activities. So that's a big thing that's different. So now I'm going to hand it off to Kristen to talk about PDRs.
Thank you. Hello, everyone. We don't want to fall off the stage. The PDR process. What I want to talk about first is what is not changing. The provider discovery review, you're still going to have, all of the providers are still eligible for a provider discovery review by area. Not by region, but by area at this point. With the exception of support coordinators, which Teresa will go into a little bit into more detail later on, and Charmaine also alluded to that as well. The process will still include an administrative review. That's where we're going to still be coming out. We're going to be looking at your policies and procedures if you're an agency, and based on the policies and procedures that are applicable to you. Looking at training, making sure all of the training has been completed and up to date. Background screening, of course, things of that nature. All of those things, none of that has changed. And we will also be doing service-specific record reviews. You see SSRR listed a lot on our slides. That stands for service-specific record reviews. That's for the individual's service-specific record. So if it's an ADT file, then that's an SSRR for that person. The other thing that has not changed is that for those of you that also operate adult day training facilities or Life Skills 3 facilities or group homes or any type of a licensed residential facility, if you receive funding for residential rehabilitation, standard, behavior focused, or intensive, we're still going to be doing observations on those locations. So that part of the program has not changed at all. What you're probably more interested in, of course, is what has changed. What's going to be different is we have added interviews to the provider discovery review portion of the process. We're going to be interviewing staff. It's a formal interview process with staff that provide services for your organization or you personally if you're a solo. We're also going to be interviewing individuals that receive services from your organization or from you as a solo provider. This is, if you think about it, it's a flip-flop from what we were doing with the support coordinators with the wraparound. We're now focusing it now solely on the provider themselves. Teresa will get into more detail about what those interview tools will look like as well. But that is probably the biggest shift that we're making with this process, other than not doing the random PCRs throughout the year, which is dropping the associated PCRs. We'll be rolling out a revised observation review checklist. And again, that's for those of you that have the Life Skills Development 3 locations in the residential facilities. I'll go into a little bit more detail about that later on. And the last major change is that with the observations is that we will be doing some of them as announced, and some of them will also be unannounced observations throughout the year. So those are the big things that are changing, and those are the things that are not going to be changing with the PDR process. And with that, I will hand it back to you.
And again, we're hitting the highlights on what's the same and what's different, but we will take you into a little bit of detail. The other thing is on the slides, when you look at our presentation on the computer, you can't see color when you're looking at your paper, but anything that's in red on the screen, those are the new tools. So when you go to look for the new tools, that's what you're going to look for their name. We want to come up with more creative names than we have right now, but so far, this is what we got. If we come up with something creative, we'll let you know what we're going to name them, but it's a PCR individual interview tool, a PDR individual interview tool. So anything that you see in red is specifically noting what a tool name is, and all our tools will eventually in the future, hopefully near future, be posted up on our website as part of that whole transparency, so you guys can go and see the tools ahead of time. So now we're going to talk a little bit about the PCR process and kind of go through the pre-review activities and what kind of goes on when we're going through a PCR. Again, support coordinators in the room are probably spending most of this time talking with you, but for providers and other people involved, if you support individuals with disabilities, you need to know about what PCRs are, because even though you're not going to directly be involved, someone you support could be pulled into a PCR, so it's good for you to understand what's involved. So the PCR sample, I already told you, it's going to be pulled annually. The tricky part with PCRs is part of our contract is we have to turn in schedules and samples for the next year in November of the year prior. So we already pulled the PCR sample for 2015, and we pulled that PCR sample for 2015 back in September of 2014. Now, it's great to kind of be ahead of the game. The one flaw with that, which we recognize, is by the time we get to going to actually do the PCRs, people have moved around. Some of them have shifted support coordinators or they shifted within an agency, so we know that happens. But it's just part of why we have to pull it early, because we have to turn in schedules and everything by November 15th, part of our contract. The other flaw a little bit with our sample is, I know you guys try really, really hard, but ABC isn't always that accurate. So a lot of times the information that we're pulling isn't the most current information, but we work with what we got. The good thing is, as much as we have PCRs selected, there's always alternates behind them. We have everything randomly sorted. So if there's a caseload for a support coordinator of 38 names, it's going to give me the chosen 2 up at top, and then it's going to randomly sort every other person that coordinator serves. So if somebody were to decline a PCR, which is their prerogative, the reviewer would then help move on to the next name in the list, which is randomly sorted. They're not hand-picking them for that piece. So that PCR sample is pulled annually, 2 people per support coordinator, and Charmaine already touched upon it, and if you didn't really get it, we're going to do support coordinators, and they're the only service provider that will do by region. And remember, Central Region would be anyone that's serving from 13 to 14 to Area 7. So it's no longer, we used to do it by area. So if you were a support coordinator and you had a caseload in Area 7, and you had a caseload in Area 13, which I know quite a few people had that, you actually got 2 reviews, one for Area 7, one for Area 13. That's now going to move to 1 per region, only for support coordination. Okay? There is always the chance that APD local region does have the prerogative and the option to ask Delmarva to still do a review by area. If they have a concern with a support coordinator, how they're rendering their services or how it's working, that is out there. But our policy is 1 per region. So that's a pretty big change for support coordinators that we'll be doing. And again, the reasoning is you can only serve so many people. Whether you do it in Area 7 or Area 13, you can still only serve 40 some odd people depending on your combination of full and limited. So that was feedback that we received, that we heard, that we went to state APD and ACA, and everybody agreed to. Now, as I said, a person can decline a PCR. You know, it's their option. We don't make people talk with us. So if they were to decline, as I already said, we would go to the next name on the list. And there are 2 PCR records reviewed plus 1 unannounced record. So for support coordinator, a single support coordinator is pretty much all the time going to get 3 records reviewed. We occasionally have exceptions to that, but that's the general rule, and that's kind of what we're sticking to. So, next. So with that initial phone call to a support coordinator, the first thing that we're going to do is we're going to tell you who the chosen PCR names are. That's the first thing you want to know. Who was picked for the PCR? The reviewer is going to give you that information. Then we're going to coordinate with you and help assist us to get those PCRs scheduled. And that is something that we greatly appreciate and we really need. The people that we're going out to interview don't really know us, but they do know you. So we really look for someone who's familiar with them and who knows them to make those initial phone calls, let them know that they were selected for review, and that someone from Delmarva would like to set up an interview with them. So we always look for the support coordinator's help with that. If we're working with a support coordination agency, there's a few more steps involved. You know, we're going to have to try to confirm all the support coordinators that work with that agency. So it could be when we pulled the sample, there were 10 support coordinators and these are the names. But again, pulled that sample back in September of the year prior. There's turnover with support coordination. People come and go within an agency, people change caseloads. So we want to get current information at the time. So we're usually going to find who's our contact person with the support coordination agency, and they'll be our lead contact to coordinate this stuff. And we're going to try to figure out who's working with the agency now, who are the people chosen for the PCR, how does that match up with caseloads, and eventually we'll work through getting your sample set up. And then, next, I think, do you have the next slide? Do I go? Okay. For your subsequent calls, the reviewer has a few other things that they're going to be trying to take care of. They're going to finish kind of gathering the information and figuring out with your PCRs and what the names are. The other things that they're going to try to do is confirm when those PCR interviews are going to take place, where they're going to take place, who decides when a PCR happens and where it happens. It's the person and the family member. You know, we usually give you a time, a week, a few days that we're working within, and then we're trying to coordinate with those individuals. What's a good time of day for the interview? Where would you like the interview to take place? And in some instances, some individuals might want a family member or somebody at the interview with them. Part of national core indicators, which I have a slide coming up, is there's a whole list of background information we need to collect. And I'll talk about national core indicators. We need your help gathering that information. You've got the central record. You can help share and provide that information for us. So we'll be doing that with subsequent calls. We're also going to schedule our time for the WSC interview. And then we're also going to schedule the time for the record review and the PDR. Support coordinators also get a PDR, which is your administrative review and your record reviews. There's still a relationship for support coordinators between PCRs and PDRs. But for other providers, we have removed that. So that's going to happen during those subsequent calls. I think at this point, this is where I cover national core indicators. NCIs, as they're called, we've been doing national core indicators in the state of Florida since 2010, when we started this contract that we have now. National core indicators is a national database, and what it allows is it's a survey. We did not write the questions, we did not develop the survey. Delmarva is simply the entity, the group. Since we were already out talking with people, it made sense for us to do the survey. So those survey questions, when a reviewer covers it, it's not something that we're doing that we developed. It's developed by a group called Human Services Research Institute, HSRI. And they developed this survey in order to gather information on a national level about the lives and the services and the needs of people with developmental and intellectual disabilities. And what it allows is if you have the same groups of questions being asked in the same way, with the same types of responses, it allows us to be able to actually compare information. The same sets of questions are being asked in Florida, that are being asked in Oregon and Massachusetts, and all around the country. So it allows them to gather data and actually be able to compare apples to apples. So it gives us really a very rich, large, I think it's one of the largest databases for people with intellectual and developmental disabilities, about their community, about their health, about their connections and their satisfaction with services. So that's what that survey is. The reviewer, when they go out to do the interview, they do this piece first. And it's the part of the PCR where they ask a series of questions and it's either yes, no, sometimes, never, I don't know. There's a whole series of responses. That's the survey piece. Our reviewers were trained by HSRI on how to do those surveys, and they get ongoing training throughout the years on that. But it allows Florida to participate in a lot of information and be able to compare that information, as I said, with the other states. So that's what the national core indicators are about. The other thing is it's not used in decision-making at all as part of the review. It doesn't get scored, the information doesn't get reported, it's data, it gets aggregated. Gets rolled up, and it's just a data point that gets used in there. So none of that information is that John said this, NCI is completely anonymous. The other part of our process, just to really talk quickly about, would be our medical peer review. We mentioned Linda Tupper's name. She's our nurse. She's been with us since the start of our contract in 2001. Every person-centered review that occurs, every reviewer that does one, it goes through Linda Tupper. She's going to screen that to look at the answers under the health summary, to look at medical claims data for an individual, and essentially try to identify are there any red flags. We have a system, I'm going to pull it up a little bit clearer, but we do have criteria that goes through whether somebody needs to get pulled into a more involved type of medical peer review process. But we're really looking at to make sure that folks are getting appropriate physical, dental, behavioral health care. Are their needs being met? Is there any red flags based on what we're seeing from what the reviewer heard in the interview to maybe what we see in medical claims? The one thing that restricts us a little bit from the medical claims standpoint is we only have access to Medicaid claims. So for folks that have private insurance or Medicare, it does really limit our view. But Linda from Medicaid claims can see if there have been a lot of hospitalizations, emergency room visits, what medications is the person taking, and she's able to kind of do a screening. And if needed, we can go into a medical peer review, request medical records, maybe call the nurse case manager at an area. It's just another layer in our process to try to ensure if individuals are spending the time talking to us, that we're kind of returning the favor and making sure they're being taken care of. Is there anything else not being met that we could possibly support a person with? That's the medical peer review process. Okay? I'm handing it back to Kristen.
Okay, what I want to talk to you about now, that Teresa went over the person-centered review process, is talk to you a little bit in more detail about the provider discovery review process. All of those folks of you that are not support coordinators that are here for the information related to you. The primary purpose of the provider discovery review process is it's to look at your service delivery system as a whole. We're looking to see how well you're supporting individuals to work towards the goals and outcomes that are important to them, and how well you're meeting their needs, what your systems are that you have in place to make that work for people. And all of that also has to line up with where we're looking at the compliance piece of it, based on billing requirements per the handbook, per Florida Administrative Code, statute, whatever other requirements, memos, or policies happen to be in effect at any given time. So those are the primary things or focuses of the provider discovery review process. During the initial phone call, there's a number of different things that the reviewer is going to be interested in finding out from everybody. One of the first things they're going to want to know is what area you provide services in. This is something that we struggle from year to year to try to keep a handle on, because as many of you may know, you may be in multiple areas, but you only have one, well, in most cases, only have one provider number. Some larger agencies do have multiple provider numbers, but if you'll only have one provider number, and based on our eligibility criteria, it's driven by claims data. So the claims, we may not know what area you're in, so it's very important for us to know which areas you're in so that we can make sure that we have reviews with you in all of those areas. We do review claims, as Teresa mentioned. We do get claims from the Agency for Healthcare Administration. They are Medicaid claims. So when we first make that first contact, the reviewers are going to have somewhat of an idea of the services that you do provide. But that is going to be one of the questions that they're going to want to find out from you, is what services are you currently providing, or what are services that you've provided in the past 12 months, because that is our review period. They are going to want a list of all of the staff that you have, if you're an agency, and their hire dates, because typically what we try to do when we're pulling employee files is to pull somebody, if you're an agency, to pull somebody who's been with you for a while, somebody who's been with you a medium amount of time, and then probably one of your newest hired employees, so that we get a range of how everything's working in your systems for training. As you guys know, there's a lot of training that has to be done right at the start, screenings that have to be done, but then there are the trainings that have to be done and updated periodically throughout your employment. they're going to want to know how many people you serve. And ultimately, this is usually one of the things they'll get from you once they get on site, but they're also going to want a breakdown of if you provide services, if you provide Res-Hab standard and adult day training and Life Skills 1, they're going to want to know how many individuals you serve in each one of those services, just to give you an idea of the detail of information they're going to want to get from you. They're also going to want to know, they're going to need to have a list of the individuals that you actually provide services to. Sometimes that can be a lengthy list, but that is something that will be used to, all of that information is necessary in order to pull the sample, in order to look at the records, make sure that the review process that we use is well-rounded and that we capture all of the services that you provide, and also to set up the interviews with the individuals that we're going to talk to, staff and individuals served. Again, the information will be matched against claims. Sometimes, lost my train of thought. Let me find it. Back here. Not an uncommon thing to happen for those of you that might know me. Okay, the sampling. Yes, based on the number of people that you serve as an organization or as a solo, you will be looking at interviewing a certain number of your staff and a certain number of individuals that you provide services to. The way that that will be done, we want to again get a global picture of everybody, of all of the services that you provide, so we're going to want to make sure that in that sample of staff and in that sample of individuals that we cover all of the services that you provide. So we're talking to people that receive everything. And again, much as with what Teresa said, on the individual side of things, if they are selected for an interview, they have the right to decline that. They do not have to talk to us. Unfortunately, as the providers, you guys are kind of have to, you're a little stuck. We will expect you guys to at least meet with us for a little bit and answer a few questions. And again, when Teresa goes over the provider interview questions, you will have a better understanding of what those questions are going to look like. We have always been talking with you, so the questions that we're going to be asking you aren't going to be anything new or scary. It will be very familiar to you and things that you have heard in the past. The one difference and thing that we will be relying heavily on you as providers to assist us with, much like we did with the support coordinators with setting up the person-centered reviews, once the individuals are selected that we want to interview, we will be asking for your assistance in setting up those interviews for us, as well as arranging for us to interview the staff members that were selected as well. So, and that, again, we know that we're going to be going into different places. That person may want to be interviewed in their home if they're in supported living. Wherever we need to go, this is what we'll do, but we'll be relying heavily on you guys as providers to assist us through that process. The subsequent calls that we make will be to finalize those details, to figure out where we're going to be going, what we're going to be doing, who we're going to be talking to, providing replacement names in case individuals have decided that they don't want to talk with us, backup plans, making sure that the dates, the locations of your review are set in stone and that we know everybody knows where they're going to be and where they're going to go. If you're an agency, it's really important too that I know we all hate to think that accidents or things happen and emergencies come up, but if you're an agency, you definitely want to make sure that you have a backup plan in place so that if you, as a representative for your agency, for some reason aren't available on that day, that you have somebody that can step in your place and go ahead and make sure that we can get things done as necessary. I believe that's eligibility criteria. Oh, nope. Providers are eligible. The eligibility criteria is determined by claims data. What we look for, and it's done electronically, once you have provided services, you have claims for at least 6 months for any one service. So if you provide 5 services and you're a new provider, once we receive claims for any one of those 5 services for up to 6 months, you will pop up on our to-do list. And at that point, you're going to go ahead and get a call from us at some point, and we'll go ahead and schedule for you. There is the 12 services that Christy mentioned earlier that are in one of the really early slides that are still the services that are eligible for review. None of that has changed. It's still those same 12 services, plus the CDC plus rep. The other exception is there is deemed status this coming year for 2015. Deemed status is a status that is determined annually, whether it's going to even be implemented or not jointly by ACA and APD. The criteria is determined by them this year. For any providers that scored in 2014, this past year, if you were 95% or higher with no alerts or no identified billing discrepancies, you will not be seeing us in 2015. However, I will say that given the fact that this is a new process, and it's not unheard of, some of you might say, no way, I'm not doing that. Correct. This does not apply to support coordinators. Sorry. Thanks, Teresa. That does not apply to support coordinators. But at any rate, what I was going to say is that because this is a brand new process, if you happen to fall into that deemed status criteria or that deemed category, you are certainly still able to go through this review process if you'd like to. I know you laugh, but it has been known to happen in previous years with new processes. There have been a number of providers that have contacted us and wanted to go ahead and go through the process. Teresa's going to talk, she'll speak to that.
No question.
Yeah, it's not a Delmarva rule. Just want to clarify that. In fact, there are no Delmarva rules. We pretty much have a contract, and APD and ACA expect us to follow what's in the handbook, any statutes, any directives, and so on. Deemed status for support coordinators wasn't granted because APD and ACA felt like what you do is so critical. It is so important that we can't let a whole year go by without knowing about, people served and how things are going. Support coordinators, you know what your roles are. You facilitate all of the services that a person is involved in. You coordinate all of the activities going on and so on. But that is the reason, just so that you're aware. It is just your value. Pardon? What, Diane? They should be, oh, well, again, not a Delmarva rule. She said they should be paid accordingly. No disagreement here. Given the additional interview process and the record reviews that will now all be done on site at the time of the provider discovery review versus, and I know not everybody, I know Teresa mentioned earlier she spoke some to those of you that have periodically been called by us throughout the year prior to your discovery review to have me pulled into a PCR. I know that hasn't happened to everybody, but when that did happen, those records that were reviewed then reduced the number of records that needed to be reviewed on site. So the flip side of that is that with this newer process, the provider discovery review process is going to take a little bit longer than it did in the past. So you expect us to be with you guys a little bit longer with the addition of the additional records. We're still going to be doing unannounced records in addition to the records that you'll know we'll be looking at based on the people that will be selected for interviews. The provider discovery reviews do still have to be conducted on site at the provider's site, their business location, where the records are maintained. That is, again, not a Delmarva rule, that is an ACA rule, and there are very few exceptions to that. It could be at an office, it could be at a group home, it could be at a family home, or it could be at your own home if your home office happens to be in if you're solo and it happens to be in your home. Our main priority is that we need to go where the records are, and where the records are stored and maintained.
Once the review process is done, this again is nothing new to our process. You will be given a preliminary findings. This is the last piece of paper that the reviewer leaves you with. They review it with you. You both look at it. You sign off on it that you received it. Again, you're not necessarily signing off on it that you agree with it. Even if you disagree with it, you're welcome to write whatever notes you want to on there as well. You get a copy of that, and the reviewer has a copy of that. And again, it is preliminary, and if anything on there is going to change, you're going to hear about that prior to you receiving your report. The reviewer will give you a call. And I know sometimes a review, you're left with the reviewer saying this is pending because they need to get further clarification from somebody, and then they call you back and everything is settled. But that will conclude the provider discovery review portion. Did I miss anything? No.
Okay. So the next few slides, we kind of went through your process and your procedures. And for the support coordinators in the room, again, it's not our decision, but we were able to at least get you the one review per region. So we had a small victory with that. But the deemed status has never been in place, unfortunately, for support coordinators. With the whole PCR sample and the rules that go in place, that's just how it is right now. But again, we really did take the feedback on the region thing. It actually came from one of our quality council members that championed the cause. We went back, we talked about it, and we were able to push that through. So that was one difference that we were able to make. So the next few slides that I'm going to talk about, and this part is probably pretty important. This is all the new stuff. This is the stuff that's going to happen that hasn't happened for those of you that have been reviewed before. So I'm going to talk about interviews. You know, Charmaine touched a little bit upon the CMS assurances, and I don't know how aware you all are of these CMS assurances that came out in March. But for anyone that's worked in the field of people with disabilities and intellectual disabilities, developmental, these were a pretty big deal. You know, for years and years now, CMS has alluded that things like this were important, but they never went so far as to actually put them down into rules. I guess they always hoped that providers would value things like choice and rights and people having their own room and being able to protect and lock up and secure their own belongings and do those sorts of things. But for all these years, they never put it down into a rule. It was just one of those things that they hoped people would just do the right thing. And after a while, and it was 5 years that CMS collected feedback from individuals, from family members, from providers, all around the country, and they came out with these new CMS assurances. And for the very first time, they put a value on these things by writing it into the assurances themselves. So for anyone that has advocated for years for this, this was a huge, huge deal. When you look at something like community integration, it's not about that the home is located in a community. You can have a group home physically right smack dab in the middle of a community. It doesn't mean the people in that home are connected to that community. You could have a home that's way out in the country. I had to relocate up to Tallahassee with my work with Delmarva in the last few years. And before that, I lived in Ocala. There's a lot of rural areas. You know, Florida's a huge state. You can have a home out in the sticks, in the farm, and it could be more connected to the community than that home right in downtown Orlando. So CMS decided what they wanted to look at was what's the person's experience? It's not about where the home is, what's the experience of the people that live there? What's life like for people in that home? And CMS actually put those down into words, they put it into rules, and this was a big deal. So now that Florida has this, and we want to keep our waiver in Florida, state APD and everyone's working to come in line with some of these things. They put values on things like, you know, people should probably have their own room if they can, or at least have that option. A lot of group homes, that's not an option that they have. Now we recognize that these things aren't going to change overnight. You can't take all these group homes that are out there that have 2-bedroom homes or, you know, 2 people to a bedroom and just decide them to instantly create private rooms for people. But as I said, the words is they put a value on it. New homes that are getting developed, for people that are in a home, if they can't get a private room there, what are the homes that offer private rooms? If you have belongings that are important to you, can you put them in a closet? Can you lock them up someplace? All those things that we probably take for granted, CMS put down in writing saying folks need the ability to do these things. So we look closely at those assurances, and when Kristen gets into her part with observations, a lot of the things that you're going to see in there, they're coming right from the assurances. It's not Delmarva deciding that this is what we want you to do. I know you think we got a lot of power, but I swear to you, we're really directed in following a lot of rules that are given to us, both from ACA and APD. And we work really closely in partnership. Doesn't mean we don't believe in a lot of those things, we do. Many of us come from, we're either service providers, a lot of former support coordinators. Every one of the managers, former support coordinator on the Delmarva team. Many years as support coordinators. Quite a few of our reviewers, former providers. So we have walked in your shoes. If we're going to spend time focusing on the experience of the person, the only way we can really do a good job doing that is we have to talk to people. That's why we made the decision to add interviews both on the side of a PCR and on a PDR. It's making for a more well-rounded process. For provider discovery review, we're going to take time looking at the paper, we're going to talk to the person, and we're going to talk to the provider, and try to make sure we got all the bases covered. Interviews aren't new on the PCR side, but the tool is. So in looking at interviews, it's capturing information both from the perspective of the person getting the services as well as the provider. Covered that one. It's gathering information specific to what's important to the person. What's their goals, their outcomes, what is it that they're looking to accomplish in life? And determining whether the services that they're receiving are effective, they're meeting those needs, that there's not a disconnect. There's many times we come across a person who all they talk about is they want to do this, and when we look at the record or we talk to the provider, they're doing everything but that. That's a disconnect. You know, we want to try to make those connections a little better. Conversely, there are a ton of providers we come across that do an absolute awesome job supporting people. They are putting everything into it in their time with the person, and maybe as a result, they're not focusing so hard on the paperwork piece. This part of the process is going to give you guys a time to shine as well, and let you say what you're doing. Let the people that you serve talk about what a great provider you are and what you're doing for them. So we wanted to try to introduce something that covers all sides of things. And it's going to start with these interviews. The interview tools that we developed have 4 sections to them, and they really got driven out of those CMS assurances. And we're calling them quality areas. I gotta tell you, we have been heavy into development and doing all this at a really high rate of speed. All through the holidays, you know, there were timelines that weren't in our control. We had to wait for certain things to come into place before we could move forward. So we moved pretty quickly. The first thing, of course, is person-centered supports. Those CMS assurances have long, lengthy sections about person-centered planning and supports, right down to everything that should be done in developing a support plan. The positive thing is we'd already been covering that pretty well for support coordinators. For years now, support coordinators have had to be able to say, did the person decide where their support plan was, who was going to be there, when it was going to be? You know, a lot of this stuff isn't that new. I think we've just tried to develop some questions and systems that are going to help us get at it a little bit better. So person-centered supports is the first part. Community is the second piece, health and safety are the other two. So you got those 4 pretty broad areas. Now community is very broad. So within community, we actually have 4 sub-areas. Within community, it has to do with where you live, where you work, what you do in your community, and who you spend time with, who your relationships are. And we have sets of questions that go into those 4 areas. Then we, of course, cover health, and we cover safety. Those are kind of foundational. CMS Assurance didn't really add anything new there. Those have always been kind of fundamental expectations that we try to support best possible health for individuals, and we do our best to ensure that they're safe. Everyone has a role in that. So that's how we kind of came up with those 4 areas. When the tools get posted, you'll be able to see the interview tools as we have them. The way they're designed right now is on the left side of a piece of paper, so it'd be like over here, you have a series of questions, and you'll see very clearly written on top, questions could include, but are not limited to. Those are the questions that the reviewer would be asking to try to get at the information that's on the right side of the page, and we call those findings. And a finding would be something that is not being supported for a person. So we might ask a series of questions about, well, how do you get your implementation plan developed? How do you decide what goals you're going to be working on? What is it that the provider's helping you with? What are they teaching you to do? How do you spend your time? And try to get for the individual how those things were developed. And then that would go to a finding as to whether they're being supported to drive their implementation plan process. There's a whole series of questions, a whole series of potential findings. The idea is based on the information you gather, the reviewers make a determination, do I have to check this box or not check this box? The other thing that we recognize is everybody communicates differently. And there are a lot of individuals who have some pretty pervasive disabilities. So their ability to be able to answer some of these questions could be somewhat hampered. I'm a firm believer, and anyone who knows me has heard me say it for years, that every single person communicates. We just have to pay attention. Whether it's their body language, their facial expressions, their mood, or whatever it is that they might be doing. So our reviewers spend a lot of time trying to pay attention to those things. But we realize that these interview tools are going to be reported on. We will allow for the ability for what we call proxies. In those instances where an individual really is having trouble providing that information, if there's a family member or a guardian or someone who knows them best that can help us gather that information, we'll be able to ask them those questions too. So we're going to try to pay attention to those things. The other thing that's pretty important with the interviews is we really had to take into consideration what's the expectation based on the service that you're rendering. If you're a supported living coach, your job, your role, what you're expected to do for a person is very different than if you're providing respite. And you're just taking care of a person while the family member is out or giving the parent a hand at home. Two very, very different services. So we have to be able to adapt accordingly as to what our expectations are based on the service that you're rendering. So first I want to talk about the PCR individual interview tool. The questions that are asked for a PCR and the quality areas, those community, person-centered planning, health and safety, all that stuff, it's driven by the services the person's receiving, and the questions, the information is gathered in the context of how the support coordinator is supporting that person. You know, support coordinators do have a tough go of it. And I don't know if it's because I spent my lot of years as a support coordinator, but you are responsible for everything, ultimately. And if something goes wrong, half the time it tracks back to the support coordinator. Fair or not fair, it's just the way that it happens. But as a support coordinator, you do coordinate for all those services. So when we're doing an interview with a person as part of a PCR, what services they get are going to matter. When we get into the questions about where you live, we're really focusing on residential settings. If you're in a family home, we're not going to ask about, do you get to choose your roommate? Can you get something out of the kitchen when you want to? Do you have privacy? Can you lock up your stuff? We hope those things are happening in a family home, but it's really not our job to police that. But if you're in a group home, or you're in supported living, then yes, those things matter. So it's going to be very important, I'll keep harping on it, when we talk with a person, what services are they getting? And that's going to help drive the information that we're going to be looking for and collecting. And for a PCR, it's the services they're getting and how the support coordinator is helping them in all those different areas. Support coordinators have a role from their person-centered planning, through helping people decide about living options and working options, and of course health and safety. It's just the nature of being a support coordinator. On a PDR individual interview side, questions in quality areas are driven by the specific services the person's getting from the provider we're reviewing at the time. So I might be talking to Mary, and she gets supported living and adult day training. I'm reviewing the supported living provider. My interview and my questions in talking with Mary are going to be about what that supported living coach is doing for her, not about the adult day training provider, because that's a different provider. So the questions in the interviews are driven by who I'm reviewing, the service they're getting, and the provider rendering that service. We actually have in the interview tools, and we're still fine-tuning some of these things. When I say, like, the ink hasn't dried on a lot of this stuff. We're still actively working on it, and still really working with ACA and APD on a few things. But we actually have prompts at the top. These questions focus for people getting rehab, supported living. Personal supports is tricky, because we're running across a lot of folks getting personal supports in a supported living situation, but they don't have a supported living coach. So, fact is, you're pretty close to a supported living coach if you're doing personal supports in those situations. So your role is pretty important. So we're going to pay close attention, and probably those questions and those responsibilities will click on. If you're rendering personal supports for someone living in an independent living situation, and there's no supported living coach in the picture, a lot of that's fallen on you. And I know a lot of those decisions are getting driven by iBudget and cost and what people can do with their money. But we have noticed it. And that's something when I say, there's also personal supports that can be rendered in a family home or in a community that's used very differently. So not only is it important about what services a person receives, but we're also going to factor in what residential setting are they in. Are they in independent supported living? Are they living in a group home? Are they living in a family home? The tools will say at the top, ask these questions, and we're actually working with our IT folks to kind of program our applications for the reviewer to, based on what services they enter and residential setting they enter, to help drive what questions get asked. So we're still kind of working that stuff out. So that's on the individual interview side. On the provider interview side, when we interview the support coordinator, so I see a person I've known for many years. Did you go? She was sitting right over there. Her name is Betty Harvey. If I'm reviewing Betty Harvey as a support coordinator, and I interview 2 people of Betty's, when I sit down to have my conversation with Betty, I'm going to talk with her about those 2 people I interviewed. The questions that I interviewed Betty about are going to be specific. If I interviewed Mary and I interviewed John, when I talk with Betty, I'm going to ask her about what she's doing for Mary and what she's doing for John. The individual interview with the support coordinator becomes part of the PCR. It's individual specific. We talk to 2 people. It's almost like interviewing you twice. Reviewers will find a way that works. They might do, let's just talk about Mary. All right, we're done with Mary. Let's just talk about John. Or you might go back and forth between the areas. But it's an individual interview with the coordinator to represent those 2 people. So that's different for a support coordinator. On a provider side, we might be working with an organization that's pretty big. Say it's an organization like Mentor. So we might be doing a number of interviews as part of this organization, and we're going to interview some staff. Kristen already touched upon it. The way we'll decide or figure out how many interviews we need is we want to make sure we talk to a person to represent every service that you're rendering. Now some people get multiple services. So I could have one conversation with Mark, and he might get supported living and personal supports and behavior analysis. So one conversation with Mark might cover 3 of those services if it's rendered by an organization like Mentor, the same group. When we do the staff and the provider interviews, sometimes we might get the specific staff that's serving the specific person that we interviewed and be able to talk a little bit about that. But we also might just get a general staff person, maybe that's not related to the interview. So it's going to be more focused on the provider systems at large, how they support people in general. How do you develop implementation plans within your organization? What steps do you take to make sure that people are included in that process? Tell me about how you do that. So it's kind of more global in that sense. Now there are a lot of small providers in the state. And there's a lot of providers that serve maybe 1 or 2 people and just do one service. Obviously, there's going to be a relationship there between the person we talk to and you, because you're going to know that person. So it's a little bit different, is all I'm trying to point out on that provider side. It could be a staff person directly related to that in that interview, or it could be the reviewer might use the interview as an example. When I was talking to Mark, he told me this: tell me about how you educate people about abuse, neglect, and exploitation, and we'll get your information that way. So that's the difference. It takes a little time to kind of wrap your brain around it. When we were developing it, it took us a little while for the light bulb to go on for us, so we were trying to figure out how it works. And I have no doubt, as we move forward and fine-tune it, that we'll probably find ways to do some things better. But you gotta start somewhere in the process. Okay. The interview tools, just to go over again, there is a PCR individual interview tool, and there is a PDR individual interview tool. There is a WSC waiver support coordinator interview tool, and there is a provider/staff interview tool. There'll be 4 of them. When you pull them up and you see them on our website, when we get them up there, at first glance, they might look the same. There will be a lot of commonality between the questions. They're all going to cover person-centered planning, community, and community includes where you live, where you work, what you do in your community, and who you do it with, and then health and safety. So they all cover that structure, but there will be subtle differences that you might not see just glancing at it at the questions. And of course, the biggest thing to remember is what questions are asked is driven by where that person's living and the services that they're receiving. And on a provider side, it's not just the services that they're receiving, but the services they're getting from the provider we're reviewing at that time. Okay? And again, we're going to have lots of time for questions on the end. We're doing well with time. I'm going to hand it off to Kristen.
Okay. Teresa covered a lot of what I was going to cover on slide number 31, which is about the selection of records. We're going to have matrices for just about everything, about how many records we're going to pull based on the number of individuals that you serve as an organization or solo. We are going to have a process to determine how many staff we need to interview. Like Teresa said in her example, if we interview an individual that you serve that receives 3 different services, that covers those 3 different services. However, if your organization serves 200 plus people, we're going to need to interview more than just that one person to get a good representation of what your organization is, the services that they're providing. And I would think you guys would want us to talk with more than just one person as well. So what we want to make sure is that we're getting a very good, well-rounded picture of how your business is running by both talking with the individuals that you work for and the staff or yourself as an organization. Teresa, I keep seeing you back there and thinking you're going to say something. I won't spend a whole lot of time on these next couple of slides because it is basically the things that have not changed. It's about the administrative side of the process. Again, if you're an organization and you have to have policies and procedures, we're going to be looking very closely at those policies and procedures. Do you have a policy and a procedure about ensuring the health and safety of the individuals that you serve? Is there a policy and procedure about medication management and storage if you administer medication? Is there a policy, do you have a policy and a procedure about your person-centered planning processes? Those are the types of things that we'll be looking for in that area. We're going to be looking at incident reports to see, we're going to be reading those and looking and talking with you about if there were incidents, how were they reported timely, and what was your follow-up if there was any follow-up necessary. Did somebody? Yes.
Just a question about the educational requirements, if I may. That work with the forces to be great.
I believe your question is if the rules change for qualifications and education somewhere along the line of being when you're hired, with handbook changes,
Yes.
are there people, is there a grandfathering in? Whenever things like that do change, directives are handed down from ACA and APD that direct us on how to deal with that. I know that with all of the different iterations of the iBudget draft handbook, there were some conversations that were had, I think primarily with supported living and supported employment, I think, were the two services that came up. Until that iBudget handbook is promulgated, we're still following the 2010 guidelines, and that's where we're at right now. But I can tell you, as of right now, the different iterations, whatever happens, happens. And when that handbook is finally handed down, that is the direction that we will go. You guys will be on that train with us.
So that would mean that if there's not,
My understanding would be if you're hired right now under the current qualifications, that you're in the handbook qualifications change, then the way it's been, I can only answer to the way it's been done in the previous iterations of the handbook. When a rule changes in the handbook, people prior to that are already working, you don't have to fire them, in other words. But I am not the law, I don't make those rules, and again, we would have to wait and see what ACA and APD, what the decisions are that come down from those handbooks. I do know that the draft handbooks that I've seen, even the most recent one that's out there, it actually says from the date, I think it says January 1st date, but at any rate, most of it's from this date forward, these rules are in effect. So anything prior to that, I know the last time something like that happened, I think it was probably with Res Hab, a long time ago, for people that were hired prior to 2003 or 2004 that did not have a high school diploma or equivalent, were, I guess for lack of a better word, grandfathered in. But that was the last time I believe something like that came up, and that was put in writing. But those types of things, we'll just have to cross those bridges when they come, and they will come. They always have. Background screening, of course, is we all know that the background screening is required. It's required of all of us every 5 years. You do have to have, used to be FDO, the FBI were two separate things. Now with the live scan, it's all one. The affidavit of good moral character and the local law in the county in which you reside. So those are the things that we're looking for as well for the background screening. And that is something, if that is not current at the time of the review, it does result in what we call an alert, which does get reported to the area office and to the state office and to ACA, and has to be acted upon, or at least you have a DAPA plan in action within 24 hours. The education and experience is the other thing that we're looking at, depending on the services that you provide. We are looking to make sure that you have the years of experience. Usually it's from a year on up, depending on the service that you provide. There are a couple of services, I believe, right now that do not require any experience to begin. I believe it's respite and maybe personal supports, but don't quote me on that. And then as you get up into the services like behavior analysis, supported employment, supported living, there are some higher expectations for education and experience for those services. Training requirements. Again, for those services, you have to have the in-service training for supported employment, supported living, support coordination, pre-service. All of those types of services, we're looking to see that you have those. Some of you guys have been providers for a number of years, many years. So if you were a supported living coach and you got that certification back in the 90s, we hang on to it. Don't get rid of it. We still need to see that. Keep all of those things, all of your trainings. We're also going to be looking to make sure that your trainings are current. The trainings that you have to have updated every 3 years is zero tolerance. HIPAA is annually. We want to make sure, we're looking to make sure that those things were received from an entity that's acceptable. We need to make sure that they have all of the required components on them, meaning your name, if it's from TCC, if you take direct care core competency or zero tolerance or all of them from TCC, there's the unofficial or official transcript. That's the only thing that we can accept. We cannot accept the test scores or your test pages. We have to have the unofficial transcript. If it's a zero tolerance from a face-to-face training, there's a specific certificate that is state office approved that we have to see from the trainer, whether it's an APD trainer or a non-APD trainer. All of those trainers know what that certificate has to be, and it has to include certain things. So those are the things that we're looking for as well. Those of you that provide services that require continuing education hours, those are also the things that we're looking for, to make sure that those things are in place. And just as a side note, with a lot of times providers ask us, well, when we ask them, how do I count my continuing education hours? I usually count them from my Delmarva review. What you need to be doing is picking a date and time and leave, that's your date. From that point, that's your 12-month cycle. A lot of providers will use initially their employee or their own hire date, because that's just the way it makes most sense. Some providers will use their birth date. Other providers will use, once they've been providing services for a while, they pick a calendar year. Just whatever works for them, but you need to find a fixed 12-month period of time and keep it at that, because our reviews are not always going to be the same time every year, so you don't want to use that as your guide. The next part of the provider discovery review process is the service-specific record review piece of it. The main things that we are looking for in the service-specific record review portion of the review, and this is something that there are some changes here. There is more so than ever an emphasis on the record and what is actually written and documented. We're looking to make sure that the needs of the person that you're serving being met. We're looking to make sure, is the service being provided at the frequency, the type and frequency identified on their service authorization or on their support plan? Does everything match? Is that whole picture together? If you're providing supported living to somebody, we're going to be looking at that implementation plan. We're looking at, is the implementation plan being driven by that support plan? Are the goals that are on the support plan also on that implementation plan, and are the strategies and objectives working for that person? We're going to be looking to make sure that the service is in accordance with the handbook. If it's supported living and we're looking at notes that are talking about you as a supported living coach taking somebody out and doing job coaching with them, that's something obviously that wouldn't be something that the supported living coach should be doing. But primarily we would be looking at what the supported living coach is supposed to be doing based on what's identified as that person's needs that is in their support plan. Again, we're looking for that complete picture. And the support plan is really the key document. Back to the support coordinators, the support coordinators know that, and as providers you know that. So you want to make sure as a provider that at a minimum you have at least the part of the support plan that speaks to the service that you're providing. You need to know what goals or outcomes the service that you're providing is working toward, is supposed to be supporting that person to accomplish, so that you can address that. Even if there's not an implementation plan, if it's personal supports, there's not an implementation plan requirement for that. But you, as a provider, want to know what's that person's support plan's goal or outcome, how is the support that I'm providing related to a goal, and what is the expectation for me to do to help that person reach that goal. The services, the way that we've rearranged the service-specific record review tools, we've broken some of them out to, we've historically had the standards, the protocols, and then the not met reasons over to the right. We have taken some of them and simplified them so that some of the not met reasons have become actual standards. We have, for example, some of the standards the implementation plan has had 2 different standards in there, whereas before there was just one. We have one standard that talks about the timeliness of the implementation plan, and then we have a separate standard that speaks to just the content. The timeliness piece of it is one that is linked directly to a billing discrepancy, because if it's not done timely, there's a billing discrepancy associated with that, where if it's just content, that's a different story. Some of the other services we've done similar things with, so that we've separated out. You have standards now where you only have service billing discrepancies only as the not met reasons. You won't have any standards anymore where there's a mixture of not met reasons that have billing discrepancies and non-billing discrepancies. And that'll make more sense when you see them. It's, again, like Teresa said, we're trying to fit all this together and make it make sense. But some of the tools will be longer. Some of you guys that have provided respite in some of the services that did not have very many standards, this is something that will be of a benefit to you, because unfortunately with the limited number of standards that were on those tools, I think there were only 10 on respite, something like that. If you only missed one, and depending on which one it was, your score could drop down to 85% just because that one happened to be a health and safety one, because there were so few standards on that tool. So by breaking them out, increasing the number of standards that are available to be scored, then that's going to benefit that service as well. For the providers, we will be looking at least one record for every single service that you provide. And we'll be looking at comparing it against the handbook, making sure the documentation has all of the components that are required for the handbook, whether it be a quarterly summary, a service log, a progress note, a support plan, implementation plan, behavior plan. All of those key pieces of documentation based on the service. We'll continue to look at those things. And again, the emphasis now with this new process, moving the record review piece of it is about the record itself. It's about what is written. The interview piece of it that Teresa has talked so much about is where we're going to be pulling the quality information from, talking with you, talking with the individuals, and pulling out the quality pieces of it. The record itself is purely about what is written and how that compares against what the expectations are in the handbook and the other laws in the administrative code and statute. I think that's it. I think we have, oh, did I skip that one? I did. Just trying to, I skipped over that one. What I get for not paying attention. All right. Sorry, the observations, another big piece. Teresa spoke in pretty great detail, and so did Charmaine, about the assurances and the big part about person-centered planning, and really about people having more choices and opportunities in their life and having more control over their life. One of the things that we're going to be looking at, the big shifts in our observation tool, is that, well, let me back up. We're still going to be doing up to 10 homes. If you have an agency that you have more than 10 homes, then we will still only be doing 10 of those homes each year. The following year, we will do the balance of those 10, however many more you have. If you have 15 homes, the following year we'll do the 5 that we did not do the year before, plus 5 that we already did. If there's a couple of agencies that it takes us 2 years to get through all of their homes before we start over. ADTs, or Life Skills 3 facilities, we will be reviewing or doing observations on all of those. So that, again, is something that has not changed. Up to this point, all of our observations have been announced. A good number of them will continue to be announced, but we also have received approval from the state office and from ACA to conduct some of our observations as unannounced observations. And we do realize that this may mean sometimes we show up and nobody's there. It's going to happen, but that's just the nature of what we're doing, and we will be doing our best to make sure that doesn't happen. But it is definitely a shift from what we have done in the past, and wanted to make you guys aware of that. The observation tool itself is broken out into 8 focus areas. Those 8 focus areas are up on the slide. The autonomy and independence, the things that we're going to be looking for when our reviewers are out there doing observations. They're going to be, again, still talking with people that are in the home. We still will be doing observations only when people are there. If nobody is home, and when I say nobody, the individuals, if it's just the staff there and none of the individuals are there, we won't be doing observations. The individuals do need to be present, at least a couple of them, before we're going to conduct an observation there. Because it's what we really want to see is the interactions with the individuals between each other, the interactions with the staff and the individuals, just the environment in which they're living in, how things are going. Is it just a smooth flowing afternoon when they come in, the way that you or I would come home from work and throw something on our bed or on the kitchen counter and grab something to snack on, or whatever your routine is. I mean, I know when I come home, the first thing I have to do is let my dogs out. And then they demand to have their snack before anybody else gets any attention in the house. But the things that we're looking at, do they get to make choices in their life? Can they come in from their afternoon activity and go take a nap? Or do they have to sit right down at the table for their afternoon snack? Do people have access, can they actually access the things that are in their house? Have modifications been made, tables lifted or lowered, or things placed on a cabinet at a certain height for people so that they can have the autonomy to go in there and actually get things themselves? They have the ability to, as long as it is within their reach. Teresa mentioned some about people having their own rooms, if that's an option. Some people don't want to have their own room. I mean, that's, again, it's a personal preference, but getting at what people's preferences are. And Diane was mentioning that she has personally witnessed where she's been in homes, and it makes her crazy or insane when snacks are locked up and aren't accessible to the individuals in their home. So those are the types of things that we have been looking at those things, but we're going to be looking at them a little bit differently now based on the assurances, and looking at if there's, and Charmaine had mentioned, we don't expect these changes to happen overnight, but talking with providers, what are some of the ways that you've identified some of these things? Are there things that could be put into place? Again, something as simple as raising a table so that individuals that use wheelchairs can all sit at the table for dinner, if that's what they choose to do. Instead of having to sit back and have dinner on their lap tray. If the table was lifted, everybody could come up to the table. Or having things that are on a shelf that's a little bit lower so somebody can access it themselves. Other examples are privacy, knocking on doors before you enter. A lot of times I know when I've been in group homes, staff will knock, but as they're knocking, they're walking in at the same time. Just taking that moment to step back and stop and wait for that response. Is personal or private information posted in a public area within a facility? And this goes for ADTs as well. I mean, it's just as easy for things to be posted, private information to be posted in a public place in an ADT as well. And those are the types of things that we're looking to make sure people are maintaining. When we're listening, part of our observation is just listening and taking in the entire environment. Is it a home-like setting? Or do things, as a person's room, does it appear to be personalized? Or when we're talking to the person, asking them how they chose, how their room was decorated, or at least their space of the room. Again, Teresa mentioned having a place to lock and maintain your own personal items, even having a key to a locked closet or something like that. Do the bedroom doors lock? Do the bathroom doors lock? Some of the other more obvious things are the medication management. Everybody that has facilities and has had us come in there, you all know that one of the things that we look for is to make sure that medications are properly locked and stored. If you have controlled medications, that they have to be double locked, they have to be locked within a box, within a locked cabinet or storage bin or some type of facility, some type of arrangement. The rest of it is just the typical things. Abuse, neglect. Are people clean? Do they seem to be happy? Are they enjoying the things that they're doing? Pretty general things, and a bunch of the same things that we have been looking for in the past. I think that. Thank you. I'm going to let Christy talk for a while.
Okay, we know that no one in this room is going to be a non-compliant provider, but if some of you want to know what that is, it starts off with each reviewer will contact you at least 2 times. If we have not heard back from you by the 24 hours after that second call, the reviewers will then contact APD to verify that we have good contact information. Once that's verified, we start a formal process where we send a written notification to APD in this area, it's Carol and Jeanette, to say, hey, we tried to contact this provider, they're not calling us back. They have 72 hours at that point to try to get in touch with you and hopefully get you to give us a call back. If that doesn't happen, then you will become a non-compliant provider. The next thing would make a person non-compliant is if we're actually doing a record review and you don't have one of your files on site and you don't give it to us at the time of the review. So that individual record can be a non-compliant record. If everybody did not hear Charmaine, she wanted to remind everybody that it is your responsibility to update your provider information, your contact information in ABC and with ACA. Their information filters down directly into our system, and if you don't update it through them, it doesn't carry over from one year to the next. Their system will override ours. Okay, lastly, if a provider is a no-show after a review has already been scheduled, that is also a situation where a provider would be deemed non-compliant. Results of a non-compliant review would be, everything would be scored as not met. And then you would have to go through remediation with APD. Okay, our PCR reporting system. What you're going to find on the PCR reports are the findings from the individual and WSC interviews. You're going to see the details of the record reviews from the support coordinators, and there's going to be alert details and discoveries, if applicable, on the PCR report. Now, all the PCR reports are available on our private site of the FSCRAP website for APD and ACA to review. All of the reports, all the PCR reports, are mailed to the waiver support coordinator and to the individual and their legal guardian if they request us to do so. Now, for the PDR reporting, it includes the administrative and service-specific record reviews. When I say service-specific record reviews, I mean the file reviews for each service. It will identify any potential billing discrepancies if that is applicable. Alert details, once again, if applicable. Findings from the observations are also included in the PDR report. Also, findings from the individual and provider/staff interviews would be included in that PDR report. These reports are also available on the private side of our FSCRAP website for ACA and APD to review, and they are all available to the provider.
Okay, we're in the home stretch. I'm going to talk very briefly about scoring. Robin's got a couple of things, and I think Kristen and I are actually going to come down on the floor with the microphone to cover questions and answers on stuff that you might have. We ask, you've been great about holding your questions. If we need to bring a slide back, we can go ahead and do that. So we'll do that afterward. As for scoring, you know, a lot of this, as I've said before, we still have a lot of stuff in development right now. We're still really working closely with our partners at State APD and at ACA. So scoring is still not something that's been clearly decided. There will be scoring on your reports, I got that much. We'll probably have a score that's going to look at how well you do with your compliance piece. Compliance is going to be the record review detail. What pieces of paper did you have them in the file? The service-specific record review tools that Kristen talked about, that's your compliance piece. Your billing has to do with, did you have the documentation you were supposed to have when you billed for services? So we'll be looking at that. The interview stuff is really what's going to get at those assurances. How well do you support your services and support individual to promote what those values are in those assurances, and that's what our interview questions are getting at. So we know we got those different components. We're still trying to make some determinations on how things will pull together. Once those things are decided and we've got that stuff figured out, we will, you know, post information on our website about scoring methodology. We've started adding tables in our reports. How was my score calculated? So you can go right to the back of the report and figure out, well, how did you arrive at the score? So I just don't have the real detail on how all those pieces are going to fit together. We've got meetings with ACA and APD later this month to try to fine-tune some of that. So just keep that in mind. So I'm going to go ahead and hand it off to Robin to take a couple of things, and I'll go ahead and step down.
All right, so this would kind of also go under the what's the same, is the reconsideration process. So you had your PDR review with your reviewer, and when they left, they handed you the preliminary findings form. And the reconsideration process is for any standard that has billing discrepancies associated with it. So for that case, when you get your report, you have 30 days if you would want to file a reconsideration request. Those requests do come to the 4 managers that are up here. We do them for each of our own areas or whatever reviewer was in that area. So you do have 30 days, and then we have 30 days to get it back to you. If you guys still have questions regarding your review, regarding training, regarding a whole host of things, Beth Strategias is in our Tampa office, as Charmaine talked about, and she is willing to answer everything and everything under the sun that she can, or she knows who to direct you towards to help you get answers.
Just one other thing I want to add in. With individuals, with the interview, with that information that we're collecting, I spent a lot of time driving home the fact that we're going to use some, my favorite term, common sense, in what the expectations are. Again, the services that you're rendering and where that person lives are going to be a big part of that. But I want to also put out there that we will take into consideration some limitations are put upon individuals for different behavioral reasons, medical reasons. All that is taken into consideration as well. But that stuff should be documented. It shouldn't just be, well, he can't do that because of this. There's got to be, if you're going to take away something from somebody or limit their ability or their access, it's got to be documented in there. So, you know, when we talk about access to food or people being, it's not just that everybody should be able to run and do that. I mean, there could be some valid reasons, but how is it decided? How is the person included in that decision? Where is it written? And how often do you revisit it? Just because there was a mistake once in their life, does that mean for the rest of their life they can never do something? These things should be time limited. So those things will be taken into consideration.
Before Teresa takes any more questions, I told you that I really pay attention to feedback that I get, and I've been getting some feedback on people's thoughts on billing discrepancies. And I heard something that was really, of concern to me, pretty shocking. I understand that some providers believe that Delmarva gets a commission or some kind of percentage off of anything identified as a billing discrepancy. And I really wanted to put that to bed right now. Absolutely not. We do not get a dime for identifying billing discrepancies. We don't get anything other than what our contract states, which is we get paid for PDRs, PCRs, and so on. So please, go ahead and share that information. I'm not sure where it's coming from, but it is absolutely not true, and I wanted to make sure that you're aware of it. Thank you.
First question that was asked is, when are these tools effective? Am I going to be scored on these right away this year? They're effective, I guess, January. We're still getting it decided. And yes, you are going to be scored on everything. Everything in these tools, there's really nothing that's new as far as an expectation that you needed to do. It might have been things that you weren't monitored on before, but the expectations that are in here aren't completely new on that stuff. The scoring piece, still getting decided on how to weight and look at stuff on the interview piece, but at this point, yes, that is getting covered. We had a CDC question. Now, on CDC, for anyone interested in CDC stuff, there have been no changes to the CDC representative tool. We might be changing when they're making some handbook adjustments. It's coming later in the year, so we put it on hold. Yep, question right here. Team status. This past year, you were lucky enough to score over 95%, didn't have a single billing error, and did not have any alerts. You can be deemed in 2015. If you were fortunate enough to have been deemed in 2014, you're up for review in 2015. It's just the way the ball bounces. Yeah. No, nice try. This gentleman here asked me if recoupment was still in effect. We changed it. We call it billing discrepancies. And we call them potential. What Delmarva identifies at the time of the review is if you didn't have a document that's required for billing and you billed for services, we're going to compare the claims, the dates it was out, and we put that information in the report. What happens after that is up to state APD and OPTA and how those things are handled. Really up to OPTA. We identify the information, we're part of discovery, they're the folks that follow up on it.
Hi, I'm Tom with QKnotes.com. Tired of spending hours writing notes? Create progress notes, case notes, service logs, and other required documentation in minutes. QuickNotes creates fast and easy notes for providers and caseworkers in every state. Quick Notes prompts you to write detailed, billable notes for waiver, Medicaid, and Medicare programs. Quick Notes is as easy as multiple choice and fill in the blanks. Each note is different every time. Call 727-841-8943 for information. Provided by a Florida-based company and easily affordable for even the smallest company, Quick Notes makes life easier. QKNotes.com, the 2-minute note.